Dr. Fisher, which we expect to be very informational. We're delighted to welcome you, albeit virtually, to the campus of Ranney School. We have been open for just over a month now, and we are delighted with the way the community has responded to the new normal, to all of our new protocols and safety measures. The students, the faculty, families have been extremely positive and supportive as we take measures to ensure the health and safety of the entire community. And it wouldn't be an understatement to say that those health and safety protocols are what will keep us live this fall. So we are delighted with, again, the progress thus far, but we always have a wary eye on local circumstances and things that have changed in relation to the pandemic. And from that perspective, that's why it's a delight tonight to have an expert here to answer questions and to inform us about COVID-19, the current crisis, and particularly what's happening locally here in New Jersey. So undoubtedly, as you all know, and as you're following the news, and we certainly do here on a regular basis, we have had some spikes in Monmouth and Ocean counties, particularly Ocean County, and I know that Dr. Fisher will speak to that. So we have a very clear view of what needs to be done and the protocols that need to be in place for us to continue to be live here on campus. And so with that, we have received a lot of advice on those protocols from the Medical Advisory Board. So the Medical Advisory Board, give a very brief history, at Ranney School is a committee that was formed a number of years ago in response to the swine flu epidemic. At that time, it served as in an advisory role, an advisory capacity. And for several years, it was present, but not terribly active. And then recently, we were able to revive it in order to help to give us guidance on our strategic planning process, which began in earnest about a year and a half ago here on campus. We expected then the Medical Advisory Board would provide feedback on things like our health and wellness and educational efforts in relation to our students and the parent community. Little did we know that about a year ago, as the committee really became active, we would be facing a pandemic, a global pandemic in March. And so as you can imagine, the Medical Advisory Board, which consists of healthcare professionals, friends of the school, parents, and trustees, has been invaluable in giving us guidance, both in the spring from March as we were forced to close, and especially in guidance on our opening protocols, our reopening here at Ranney. And none more valuable in that work than Dr. Meg Fisher. So it's a delight to be able to welcome her tonight. Again, Dr. Fisher's background, as I'm sure many of you know, is extremely impressive. She is an expert in pediatric infectious diseases. She is the director and of the Unterberg Center for Pediatrics, and she is the Children's Hospital. She's a professor at Robert Woods Johnson. She has literally written the book, as well as a lot of articles on pediatric infectious disease. She is really a renowned expert, but also just an incredibly delightful person, grounded and very helpful as we have dealt with the pandemic thus far, and giving us a lot of sage advice on and guidance in our reopening practices and protocols. So with that, again, it's a pleasure to welcome Dr. Fisher, and I'll turn over the mic to her for an opening session and then for some questions and answers. So thank you again, Dr. Fisher, for being here.
Oh, it's a pleasure for me to be here. Thank you for inviting me. And it's been a pleasure to be part of the Ranney family in this way. I'm delighted that you have been able to open. And what I'm going to do tonight is really try to give your families and your students, if they're watching, a little update on what's happening with this COVID-19 pandemic. Now, as you know, this started in Wuhan, China, back in December of 2019, and it rapidly spread through China and then to the rest of the world. So that by the end of January, the World Health Organization declared this a public health emergency. The United States followed on January 31st, calling it a public health emergency. By the middle of March, this was considered a pandemic because it had literally affected pretty much every country in the world. Now, our first cases in New Jersey were in March. March 4th was our first case. And then we had a peak incidence of disease in February, where we were seeing thousands of cases a day, actually 4,000, in excess of 4,000 cases a day through much of April. Our numbers began to drop very nicely in May, came down in June, stayed down in June, July, and August, and only recently have begun to pick up again. And for the first time, we went above 1,000 a few days ago. So this is something that we need to be aware of. And I think part of the reason that the incidence of disease is increasing is because we're all getting a little tired of COVID, and we're letting down our vigilance, and we're allowing the virus to once again spread. So let's talk about COVID disease. What is it? So this is a disease that's caused by this SARS-CoV-2 virus, and it can cause anything from no symptoms at all. You feel perfectly fine. You don't even know that you're infected. You don't know that you're transmitting the virus to other people. Or, depending on whether you have other underlying problems, you can get extremely sick, end up in an intensive care unit, need ventilatory support to stay alive. And in fact, unfortunately, we know that many people have died from this disease, literally hundreds of thousands. So clearly, a disease that we would like to be able to recognize and like to be able to stop. The symptoms of COVID-19, when you have symptoms, are very similar to those of influenza. So it's going to be very confusing as we go through influenza season this year to try to figure out who has influenza and who has COVID-19. One of the unique symptoms of COVID-19 is a loss of taste and a loss of smell. The good news is that loss of taste and smell is transient, and it does come back in the vast majority of people. Now, how would we know whether you have COVID disease? Well, the best way to know is to get the PCR testing. There are several diagnostic tests out there. The most sensitive and the most believable is the polymerase chain reaction that looks for the nucleic acid of that virus, and you can detect that in the nose, in the saliva, and in patients who are in the hospital from things like sputum or other cultures. Even stool can detect some of this virus. It's important to remember that that PCR test is exquisitely sensitive. So it becomes positive as soon as the virus is in your respiratory tract, but that test stays positive for weeks to sometimes months. So it stays positive long after you are no longer contagious. So whereas we used to recommend repeated testing, we're not recommending that so much anymore. Now we're kind of working on a symptom-based strategy as to when a person is contagious or when they're likely to be contagious and when they stop being contagious. The vast majority of people are contagious for about a week. If you have some kind of immune compromising disease like cancer, an organ transplant, and a problem with your immune system, then you may stay contagious for a little bit longer. Now, clearly, this is something that we would like to protect ourselves against, and we certainly want to protect our children against it as well, and all of the staff at Ranney who are teaching our children. So how can we do that? In order to protect ourselves, we need to understand how the virus is spread. And we now know that most of the time, the major way that this virus is spread is by droplets. What are droplets? Droplets are those little spit things you make when you talk, when you sing, when you shout, when you express yourself. You shoot out those little droplets of saliva, and if you're infected, the COVID virus, SARS-CoV-2, goes out into those droplets. Now, these droplets that occur when you talk usually fall to the ground harmlessly within about 3 to 6 feet. They may fall onto a surface. If you're standing up close and personal with someone, they may fall into that person's nose or onto their eyes. So this is the kind of direct transmission that occurs from a person who's infected to a person who's not infected. So if we want to stop the spread of those droplets, how can we do it? Stay 6 feet away, because if you're 6 feet away, you're not going to be in line with most of those droplets. And then wear a mask. The idea of the mask is to protect yourself from inhaling those droplets. And also, if you're infected and you don't know it, but you're wearing the mask, you're going to dramatically decrease the amount of virus that you put out into the air. Now, there's been a lot of discussion about aerosols and airborne infection. And occasionally, this virus does get aerosolized. We can aerosolize almost anything in the laboratory. And sometimes this virus is aerosolized and goes a little bit farther than that 6 feet. But that's the exception. And that's called a super spreader event, where for whatever reason, the virus gets into these small droplets that go a little bit further. But the major way it's transmitted is those larger droplets that you can stop by use of a mask. Now, how do you wear the mask? Well, this is important. It sounds very simple, but I can't tell you how many people I see that are not using the masks appropriately. This mask is a procedural mask. It's used in the hospital, but these are now readily available. You can buy them over the counter. What you do with this mask is you put it over your nose and your mouth, and this is the important part. It needs to cover both your nose and your mouth. When you take it off by the ear things. Not everybody has these masks. Some people prefer the cloth masks, and there are a variety of these. Here's one that has ties so that you can tie it in place. Here's one that has ear hoops so that you can use the ear hoop and put it in place. Some people have masks that match all of their outfits. The cloth masks are not quite as effective as the procedural masks, but they do the trick. As long as there are a couple layers of cloth, they prevent most of those droplets, and they are very important. But you need both. You need the mask and you need the distancing. Now, as a pediatrician, I call it physically distancing, not socially distancing. We don't want people to be socially distanced. We don't want people to be isolated. We know that this pandemic has been horrible for everyone, and especially for our children. And we don't want to think about telling them all the time they have to be socially distanced. No, we want them to socially interact, but we want them to do it at a physical distance. So that's the most important ways that we're going to prevent the spread of this virus. Now, pretty soon, I think, maybe by the end of this year or into next year, we probably will have a vaccine, and we are very much hoping that that vaccine is going to work. And because of the way that the government has planned vaccine production, it is likely that we will have a lot of vaccine within a relatively short period of time. When it becomes available, we'll know exactly what you need to do, but we will really want everyone to get that vaccine. In the meantime, we also want you to protect yourself and your children against other diseases. We think this year, particularly, everyone over 6 months of age should get the flu shot. And you should get it now. You should get it before the end of October. So get the vaccine shot, the influenza flu shot. You can get it at almost any pharmacies. For children, they should get it from their pediatrician, and be protected against influenza so that we don't overwhelm our healthcare system with influenza disease when we're still in the midst of a little bit of uptick of COVID. Now, we said in New Jersey, it's just a small uptick, but in the rest of the country, there are 40 to 50,000 new cases every day. So this pandemic is not over, and it behooves us to remain vigilant. I think we've seen this uptick because everybody's tired of COVID, and people are forgetting to do those simple things. Wear the mask, wear it properly. It has to be over your nose and your mouth. I can't tell you how many people I see walking around like this with their mask. This is protecting my chin, which is no protection at all. This is also not protecting because my nose is out and I'm exhaling virus into the air, or I'm inhaling virus from the air. So it's got to be up over your nose and covering your mouth, and it will be protective. And then you also want to do the physical distancing. Now with that, I think what we'd really like to do is give you a chance to ask some questions.
Wonderful. Thank you so much, Dr. Fisher. We've got a number of questions already, and if people want to go ahead and enter in their questions to the Q&A, we'll ask them as they go. But the first question for you, Dr. Fisher, you talked a little bit about transmission through droplets. Now, and this came up in one of the medical advisory board conversations, if you're an asymptomatic carrier, how likely are you to be producing droplets that would infect people?
Very likely. So whenever we talk, even when we're not infected or when we are infected, we're making droplets every time we open our mouths. So literally with every word, you're sending some droplets out there. And if you're infected, those droplets may have the virus in them. It's estimated that at least 30% of people who get infected are infected by asymptomatic contact.
So New Jersey has opened up indoor dining to 25% capacity. How risky is indoor dining, and what recommendations do you have to make that as safe as possible in schools?
So anytime you're going to come into contact with people other than your family members that you've been spending time with, you are going to put yourself at some risk. Now, you know, all of life is risk versus benefit. It is very beneficial for us to get together with people, to socialize, to, you know, enjoy their company. But if we have risk factors, and personally, you can tell by my white hair, I'm at risk. I'm at risk simply because of my age. Many of the parents are going to be at risk because they have other medical problems. Some of our children are going to be at risk because of those other medical problems. So we can't just think about what's the risk if I go to a restaurant. We have to consider what is my risk if I do get infected. Am I a high-risk person? We know that overall the mortality rate of this disease is thankfully quite low, down in the range of 1% to 2%. But for someone over the age of 70, the risk jumps to 15%. So we want to protect the people who are at that higher risk. And that means if there's someone in your family who's a high-risk person, you probably should not yet be out going to restaurants and being exposed to other people. On the other hand, if everyone's healthy, you want to try it, take a look into the restaurant, see how well people are physically distanced, and see if there's, if there's 15 people at a table, I don't care if the tables are 6 feet apart, there's no way those 15 people are 6 feet apart. So look at the setup and see whether you think that's going to be safe enough for you. If you're not sure it's safe enough, then don't dine indoors. Just because you're dining outdoors, if your table is right up close to the next group, or if there's 5 or 6 people that you don't know at your table, that's another risk. Not as big of a risk as inside, but still that close contact is what we're concerned about for transmitting the virus.
Okay. And a related question, is it safe for students to play sports indoors, and how is it possible to play sports without masks?
So we don't want children who are actively engaged in sports to be wearing masks. Obviously, if you were swimming, we clearly would not want you to wear a mask. Where we would like those children to wear a mask is when they're on the sidelines and when they're on the bench. So if you're running around, even if it's indoors, let's take a large gym with high ceilings and a group of people playing basketball. Those basketball players, yeah, occasionally they're in each other's face, but it's not for any prolonged period of time. On the other hand, watch the kids on the bench. The kids on the bench are shoulder to shoulder. They are not 6 feet apart, and many of them are not wearing masks. If you're going to play sports and you're on the sidelines, you need to put the mask on. It's protecting your teammates. And increasing the chances that you can get through the sports season. So I think that many children can play sports safely inside. I don't know about wrestling. I think the contact you have in wrestling may not be safe, but for basketball, certainly it's fine. For the outdoor sports, field hockey, soccer, lacrosse, football, those appear to be safe. But again, the risk is going to be when you're sitting on that bench, shoulder to shoulder, screaming to encourage your teammates and making tons of droplets that are going right to the person next to you.
Wonderful. More questions about, so we've been really lucky at Ranney in terms of reopening, not having any cases, any transmission, knock on wood. Obviously, we've been able to eat outdoors quite a bit. We've had a great fall. Do you think that there are any lessons in terms of what's been working in terms of reopening schools? And a related question, do you feel like opening windows in classrooms is enough to kind of replicate that as we go into winter months?
So unfortunately, all schools are not equal. I think you have done at Ranney a wonderful job of making your school as safe as possible. So you've taken the small classrooms and you've gotten rid of them and moved people into larger settings where there's better airflow. The amount of air exchange does matter, and just because you open a window doesn't necessarily mean you get more air exchange. So it depends how much breeze is going on outside, how much ventilation is going on inside. All of those things do make a difference. And I think that the reason you're having the success that you are having is that you've looked at your classrooms, you've looked at the settings, you're making sure that physical distancing is possible, and you've been able to do things like eat outdoors. What will happen in the winter is we're going to have to find other ways to ensure that we're physically distancing while we're eating lunch, because you can't wear a mask and eat lunch.
Definitely. Now, you mentioned, actually, although COVID is still spreading, there seem to be fewer cases in the hospitals in critical care than we saw over the summer. Is there any, do you see any reason for that?
So it appears that many of the cases now are in younger individuals who may be a bit more healthy, so that it's not the same group that we saw before. If we look at the many deaths that we had in New Jersey, and we're talking about almost 15,000 deaths in New Jersey, about half of those deaths are in people who were in long-term care facilities who had lots and lots of comorbidities, other problems in addition to just COVID-19. So the cases that we're seeing now are tending to be in a little bit younger and more healthy people. We've had outbreaks on the college campuses. Those are definitely a group that is at much lower risk for severe illness. Our concern, though, is that these college people will give the disease to their professors and to the other people in their environment who might be at higher risk. So we are seeing less cases, but the numbers in New Jersey of hospitalizations went from a low below 100 to now literally hundreds, and I believe the number was almost up to 900 today. So it's not zero, and some of these patients are in intensive care units, but there's no question that patients do seem to be doing better now than they were during the peak of the epidemic. And I can't totally tell you why. We don't have evidence that the virus has actually changed in any way, but it certainly is acting a little bit differently, which is it's a wonderful thing if it's making people less ill.
Okay. I know as we head into flu season, and you mentioned, a lot of the symptoms of flu and COVID are similar, with one, the loss of taste and smell being unique to COVID. How often does that occur? And as parents watching our kids with symptoms, at what point should we be really worried about COVID? And when during the cycle of COVID incubation is it best to get a test? That was a lot wrapped up into one.
Yeah. So this is kind of the bad news. In children, influenza is actually a more severe infection than COVID virus. So when your child has a fever or has a runny nose or has headache, it is possible they have COVID. So there's you know, the only time you can be really think, oh, I'm really worried this is COVID, is if they would lose their sense of smell or their sense of taste. How common that is really is, it really depends how much people are asked the questions. So in the initial studies, nobody talked about this. Then all of a sudden people began reporting it. And in one series, 80% of people who were hospitalized had some loss of taste and smell. But it may be, you know, if you're very sick, nobody's asking you about, oh, by the way, does that hoagie taste good? You know, so it probably was just not asking the question well enough. We don't know in children how common the loss of taste and smell is. It really has not generally been reported. So I think you do have to worry about your children when they're ill, that this could be COVID, and you have to think about whether or not they've been exposed. If you know that there's been an exposure, the best time to test your child is 5 to 7 days after the exposure. Why do I say that? Because the incubation period is anywhere from as short as a couple days, but usually 4 to 5 days, up to 14 days. So when you've had a definite exposure to someone with COVID-19 virus, proven disease, you are supposed to self-quarantine for 14 days. The reason to do a test is to identify people who are infected a little bit sooner so that you know what to do with their siblings and with their other family contacts. It doesn't mean that if they're negative, they can come off of isolation. So a test at day 5 only says you're not shedding the virus at day 5. It doesn't say that you won't start shedding it at day 7, day 8, day 9, day 10, up to day 14. So we want to do tests of people who are exposed, but we really need to remember what you're going to do with the result. So a positive result, that's easy. Your child's infected, they need to stay away from other people. And how long they stay away? If you have no symptoms, it's 10 days from the positive test. Then if you haven't developed symptoms, you can go back to being with other people. If you do develop symptoms, then it's again, at least 10 days, but your fever has to have gone away and your symptoms have to be better. Oddly, if you don't ever develop symptoms and you test negative, you have to stay isolated for 14 days. Why 14 days? Because that's the incubation period. So although it doesn't seem fair, if you have an exposure is 10 minutes of face-to-face contact without a face mask, okay? That kind of an exposure is a high-risk exposure. You need to isolate yourself for 14 days.
Okay, wonderful. Changing gears to vaccines. A lot of questions about vaccines. Obviously, there are several vaccines in development. You know, what are your thoughts, one, in terms of when it might be available in whatever form to children? And are there any risks, you know, as parents thinking about vaccinating our children, what are the risks? And one other very specific question about children born outside of the United States who might have had the BCG vaccine and whether or not that offers protection in terms of reducing the severity of COVID.
Let me start with that one. There have been interesting studies here and there that suggest that people who had BCG or get milder cases, or people who have had measles vaccine get milder cases. None of those have actually held up in very large numbers. So I think we're unfortunately going to have to wait until we actually have a COVID-19 vaccine. As far as when it will be available for children, that one's pretty easy. Children are at the bottom of the list for people to be immunized. Why? Because they're not the ones that are getting the sickest from this pandemic. And in fact, we don't think they're the major transmitters of disease. We know that children are often infected by their parents rather than the other way around. So children are not high on the list for who's going to get the vaccine when it becomes available. Now, that's not bad news. That means that we will have a lot of experience with the vaccine before we start giving it to children. So we'll have a lot of safety data, we'll have a lot of efficacy data, and I think for as a pediatrician, I'm kind of happy with that. Children are not yet included in the vaccine studies. It's very likely that we will have to have some studies that show that the vaccine is also safe in children before we start giving it to all children. So there probably will be studies which begin to enroll children. And the American Academy of Pediatrics has called for those studies really as soon as possible, because we would like to get ready. We would like to know if children are going to be protected in the same way, and if children are going to have different side effects than adults might have. Lots of unknowns still about the vaccines, and there are over 150 of them being tested across the world.
Now, do you think that there is some possibility of the concept of herd immunity? Or do we think that we're really reliant on a vaccine to be able to end any of the lockdowns and social distancing?
So if we remember what it was like in New York City and New Jersey during April, where we were having 4,000 to 5,000 new cases a day, even with that extent of disease, the percentage of people who were infected is only about 20 to 30% of the population. In order to get herd immunity, we probably need more like 75 to 80%. So I hope that we're not going to have to get to herd immunity by having that many people infected, because then there's going to be a lot more morbidity and a lot more deaths. What I hope is that we will have a vaccine. That vaccine will probably be targeted for healthcare workers first, then for high-risk individuals, and then it will be rolled out to the rest of the population. And again, by the time it gets to children, we will know a lot more about the vaccine. And I suspect it won't be one vaccine. It will probably be at least 2, and more likely 5 or 6 vaccines that get approved for use within the next year.
What are your thoughts about making the influenza vaccine mandatory? And I guess as a related question, the COVID vaccine mandatory eventually?
So I am very enthusiastic about vaccines and about the fact that vaccines save people's lives. Unfortunately, at this time in our country, mandates really make people upset. And unfortunately, sometimes people react the exact opposite. If I say to you, you have to do it, you say to me, no way, I'm not doing it. So I'm not sure that mandating COVID vaccine makes sense right now, especially when we don't even have a vaccine. And we're only going to have limited supply at the beginning. So I'm not sure that the mandates will be successful, and I'm not sure that they'll be tolerated by the public. I have to tell you though, mandating vaccines for school, the regular vaccines, has been very successful at getting all children immunized. The other thing mandating vaccines does is it levels the playing field. So you don't have to say, can you afford to pay? Can you afford to get this vaccine? If it's mandated, it's actually provided at a reasonable cost for everyone. So in that sense, I am definitely not against mandates, but I think we have to see how this plays out. As far as mandating influenza vaccine, we do mandate influenza vaccine for healthcare providers. So in my hospital system, you have to get an influenza vaccine unless you have a medical exemption or a religious exemption. And I'll tell you that very few people in our hospital have either the medical or the religious exemption. It's less than 5%. So we have mandated vaccines for healthcare providers. We also have mandated vaccines at school entry for the youngest children and children in childcare. But I think that people's appetite for mandates, again, sometimes it just makes people more angry than it is helpful. So I would hope that we're going to be smart enough to be able to get our population vaccinated without the use of mandates. I'm an optimist.
I love it. Thank you. A question about performing arts. Is there any way to sing or to blow into brass instruments safely indoors? We've been doing it outdoors to date.
That's a absolute, we don't know. So we know that the droplets that are produced when you sing, particularly, if you have someone who's a really good singer and you have lots of them at Ranney, when they project, or someone who's in a play, who's projecting their voice so that people in the back of the auditorium can hear them, they're going to be making droplets. And if those droplets are infected, that does set up a situation that may not be safe. So I think until we get the vaccine, I'm afraid most of the singing is going to have to be outdoors.
Now, a few other countries are experiencing second waves. What are your thoughts in terms of whether or not that's headed in our direction, and whether or not you think, I think one person asked a question about the WHO changing guidelines in terms of lockdowns being a solution to stopping transmission. What are your thoughts in terms of whether that could be possible again?
So I think, it's a very difficult situation. I think there's no question that that isolation and lockdowns were a major reason that COVID-19 was controlled in New Jersey. There's no other reason to explain why the incidence of disease dropped so dramatically. On the other hand, we know that our economy has been devastated. We know that people are out of work. We know that children are tremendously affected by the fact that their parents are out of work, and that there's so much economic burden. So I think somebody's got to weigh all those risks and all those benefits, and they need to make a public health decision that we're all willing to abide with. And I think we haven't done a good job at abiding with public health recommendations. The fact that I can walk around my town, Seabright, and not see people wearing masks means that people are still not paying attention to public health recommendations. So I'm a little concerned about that, and I'm concerned that this little uptick that we're seeing now could be the beginning of a much larger uptake. And again, I think it's because people have gotten tired of following the rules. We've opened up things so that people are interacting more, and we've seen that the virus can spread under those situations.
Now, we've been very careful at Ranney about cleaning surfaces. We talked about droplet transmission. How likely is it for someone for you to transmit COVID by touching an infected surface?
Thanks. It's something that I should have elaborated on. So remember, I was talking about the droplets and how some of them will fall onto a desktop, onto a computer top. If the next person comes around, touches that computer top, there may be virus left on that computer top or the doorknob or the desktop. And if that person then rubs their eyes or picks their nose, then they may put the virus directly onto their mucous membranes and get sick in that way. That is a major way that the common cold virus is spread, and it's a way that influenza is spread. It doesn't appear to be nearly as important for COVID-19. Why? I can't tell you. I'd get a Nobel Prize if I could tell you why. But it doesn't seem to be as important. What seems to be most important is that close face-to-face contact, those larger droplets. So droplets number one, occasionally aerosols, and occasionally tabletops, what we call fomites, so getting the virus onto another surface. But those appear to be very much less common ways that the virus is transmitted. Doesn't mean you shouldn't wash your hands. Wash your hands. Remember, all of the things that I've said protects you against COVID-19, protects you against influenza. So physical distance, wear the mask, wash your hands, and you won't get flu this year. But you can do even more. You can get a flu shot so that if you do get the flu, you won't get nearly as ill, you won't end up in the hospital, and you won't end up in intensive care.
It's a good thing I don't have to wipe down my groceries anymore. That's also good news. I have a couple questions on antibody testing, whether or not it's worth doing. You know, I've heard stories about people getting the antibody test and finding they have antibodies, not knowing they had COVID. And is there, so we'll start with that one.
So yeah, absolutely. If you've been in contact and you're not sure whether you had it or not, and you never got the PCR testing, you can get the antibody test to see whether you made antibodies. There's a lot we don't know about these tests. All of the tests for COVID antibodies are new tests that have just been developed in the last 6 months. All of these tests are being are out there under what's called an emergency use authorization. Normally, before you would release a test to the public and say this is a good test, you would have lots and lots of information, lots and lots of data saying that the test works. We don't have that information for the vast majority of these tests we're currently using. So we don't totally know how good the tests are. What's even more frustrating is if we find out you have antibody, we don't know how long that antibody lasts, and we don't know how protective it is. Does it totally prevent you from getting disease? It seems like it does, because we know that we're not seeing second cases in people who had COVID before. So we think that antibody is likely protective, but we don't know how protective, and we don't know how long. So is it 3 months? Is it 6 months? It would be wonderful if it was several years, but we just don't know that. For other COVID viruses that have been, or for other coronaviruses that have been around for decades, we know that the protection does not appear to be totally long lasting. So it's another big question mark in the tremendous army of question marks.
One other question we have is how many COVID cases would have to be present in the school before we would close? I think I'll start and I'll kick that over to Dr. Fisher and Dr. Griffith. Our quarantine policy outlines a number of different reasons why we would close, but it ultimately comes down to contact tracing and whether or not we feel that there's been an outbreak in the school. Dr. Fisher, I don't know if you want to jump in and elaborate on what that means a little bit more.
So I think one of the things that you've done is you're working with your local health department, so you know how much disease is within the community. So let's say you have 2 people in different classes that got their disease in the community and happened to, you know, be identified. They didn't get their disease at school, so that wouldn't be a reason to close school. But it's very tricky because, of course, we don't always know when to close the school. So you have developed very nice guidelines, and I'm going to leave that to Dr. Griffith to kind of, because I don't remember them off. Honestly, I don't remember them off the top of my head, but I know he knows.
You just...
I think I'm going to unmute myself. Yeah, thank you, Dr. Fisher. And again, this has all been incredibly informative. As Jennifer said, the point the school again, Jennifer mentioned how critical contact tracing is. We have a lot of contact with the local health officers here in Monmouth County, and they would help us to make that determination. I think, as a lot of folks know, there have been local closings in a few of our peer schools. I think CBA recently had a closing for about 2 weeks based on the number of cases, and presumably the contact tracing within the community may have indicated that it was higher risk because of where the where the virus had presumably originated in that community. So again, it's hard to say what the what the number is, but clearly that's something we'd have to defer to the health department and others in making that determination.
And in every case, we, as Dr. Griffith and Dr. Fisher alluded to, were in contact with the health department, and we try to identify where cases originated, so that if we identify that there are cases that seem, for example, one person in middle school and one person in upper school, who they seem like they shouldn't have gotten it at school, but they both did, it speaks to an underlying infection rate that is bigger than what we even know. So that's the point at which you start to close divisions down or the whole school down 14 days.
Right, and I guess I'd just add to that, and I'd ask Dr. Fisher this question. It seems as if the the rate is going to be largely dependent, or these decisions in the broader community be largely dependent on local conditions, right, and a sort of outbreak in the community at large. So I know you had mentioned, Dr. Fisher, and probably a lot of folks who've been tracing this are familiar with this, but there's a kind of color-coded system, right? I think you'd mentioned the other day on our medical advisory board call. So you could walk us through that in terms of, where that would be indicative of a situation that we feel is a broader community threat. And therefore, in our case, I'd hasten to add, and I think all the parents on the call know this, obviously, because we are able to do both remote learning and learning live, and because 90+% of our parents and children are here live, but we certainly have that option. We are always going to defer to that safe option if there were a community outbreak. But I'm curious, can you sort of walk us through what that system is, kind of the color-coded system, Dr. Fisher?
So the state of New Jersey puts out every week a map of New Jersey, and each of the counties is given a color. If you're green, it means that your rate of transmission in that county is very low, and you feel very comfortable in having your schools open. If you're yellow, it means that you're, in that transition caution zone. If you're red, then there's widespread transmission. So the good news is nobody in New Jersey is in the red. If we looked 2 weeks ago at that chart, there were only 4 counties that were yellow, and they were in the south. It was Salem, Camden, Gloucester, and Burlington County were yellow. Then the next week, it moved to the north, and it was Ocean, Monmouth, Union, and Middlesex counties were now yellow, and the southern part of the state was green. Unfortunately, the most recent graph, everything from Central Jersey down is now yellow. Interestingly enough, where we had the biggest outbreaks in Bergen County and the northern counties, those have stayed green, and we sincerely hope they continue to stay green. But it's those kinds of things that help us determine when we need to close the schools, when we need to be worried about a community outbreak. I think we can all agree that children get a lot out of school, and school in person is really ideal. For many children, remote learning is okay, but I don't think you can say that for most children it's superior to in-person learning. So whenever we can, we want children to have that ability. And of course, whenever they can have the opportunity to do sports, we would love for them to have that opportunity, but it has to be when it's going to be safe for them and safe for the rest of your students.
So can I ask a question as we're looking at data points for those who are tracking this in the New Jersey COVID dashboard, right, which is a wonderful resource, right, Dr. Fisher, and other places. Where would you put, say, a transmission rate and the positivity rates and other factors in terms of alerting not just Ranney, but schools in general, communities to risk?
Sure. So we want the transmission rate to be 1 or less, right, meaning that for every infected person, they only infect one other person.
And that's been a little higher. I'm sorry to interrupt. Yeah. 1.116, I think, today. Is that right? So just a little.
Yeah, it's 1.16. And unfortunately, in the central region, it's been as high as 3.
Right.
So that's what we don't like, and that's what starts to get people nervous. When you're starting to get up into that 3, 4, 5 range, where one student is going to infect 5 other ones, that's when you have to begin to say to yourself, is it still okay for them to be doing in-person school? And again, that's where your health department's going to help you, because maybe they're going to say, oh, by the way, you know, we just had an outbreak that really is limited to Tinton Falls, and it's not in Long Branch.
Right.
Or maybe it's in Long Branch and not in Tinton Falls.
Right.
So it really, for infections, it's really true. Everything's local.
Okay.
I think I skirted your question because I don't know that we really know the answer.
Yeah.
Well, I think we're almost to 7 o'clock. So I'll just take one last question, Dr. Fisher, and then we'll let you go. You've been so generous with your time tonight. Do you have any kind of final words of advice as we head into winter? How can we allow our children to be social outside of school? Can they have play dates? Can we socialize indoors, or should we be moving to virtual socialization as it gets cold?
And I'll just interrupt to say, I love your distinction between physical and social distancing. And you know, we are very guilty of having a lot of social distancing signs and reminders at Ranney, but it is, you know, incredibly important to remember, as you say, that the social connectivity is one of the greatest benefits of school. Social emotional learning, you know, we all know, you know, instinctively and certainly as educators, is incredibly important. So I like that distinction between physical and social distancing.
Right. I wish I had one recipe that fits all, but you know, this is going to depend on your family. What you can do is really going to depend on who's in your family and what their risk factors are. I happen to have a teenage boy who lives in my household. Unfortunately, he's a risk to me. So we have to, and even though I come to the hospital and work, when I'm in the hospital, I'm wearing, you know, full PPE and I'm protected. When I'm at home, I'm not protecting myself in the same way. On the other hand, if you're in a family where you have 3 or 4 people in the family, everyone's healthy, no one's at risk, then I think you can be a little bit more, you can do a little more outreach, you can do a little more socializing. But be careful who you're socializing with, because remember, if they have an at-risk person in their home, you don't want to infect them have asymptomatic infection and infect their aunts, uncles, grandparents, or the person who's undergoing cancer chemotherapy, or the person who just got a kidney transplant. So it really very much depends on the risk factors of the people who live in your house and the people that you're going to be around. So this is a time when we need to think about ourselves, but we also need to think about all the people that we're in contact with, and we have to be careful. And I will tell you that the teenager who lives in my house actually wears his mask when he's on the bench playing basketball. And unfortunately, he's the only person who's wearing a mask. So my message to you guys, I want kids to engage in sports. I want them to be able to do lots of stuff. Take the easy precautions. Have them wearing masks. When they're sitting on the sidelines, don't have them shoulder to shoulder screaming, you know, cheers to their friends. I want them to cheer for their friends, but I don't want them to do it in the face of another student, because then it doesn't matter if you're outside or inside. If someone's screaming directly into your face, those droplets certainly may infect you. So those would be kind of my parting thoughts. You really, each situation is a little bit different. We don't want to have everybody in bubbles, but unfortunately, some people are going to have to be in a bubble until we get a vaccine that works, or until we figure out exactly how we can make everyone safe from this virus. So I wish I had better news on that, but I really, truly am optimistic. And I think if we get back to basics, wear the masks, physically distance, and when the vaccine becomes available, get ready to get it.
Fantastic.
I love to, Dr. Fisher, to end on that note about community, in the sense of community and our obligations to others. You know, we have, as I know you read and are aware of, the Panther Pledge here that really sets out what our expectations and protocols are of all of us in community together here at Ranney. And it's incredibly important that we keep that first and foremost. You know, our individual desires and freedoms, you know, can't come at the cost of risk to the community at large. So again, we're so delighted we're here live with the option of remote learning, but we want to keep it that way. So as we head into breaks and Thanksgiving and all of those things, we'll be sending a lot of reminders to the community about travel, and other risk factors that we really, really want to mitigate in order to make sure that we're able to get through the semester and ultimately the year successfully. So, but thank you so much for all of this incredibly sage advice and your informative talk tonight, Dr. Fisher, and all your work on the Medical Advisory Board. I want to thank Jennifer, who put this talk together, and Sarah Zavorik, who is our Director of Communications, all the other folks who contributed to it, and again, all of your colleagues on the Medical Advisory Board who have been so incredibly helpful to us as lay people as we're coming to grips with what has been a really challenging circumstance, but certainly much easier for the advice that we receive from people like you. So thank you so much, Dr. Fisher. Really appreciate it. Look forward to meeting with you again soon.
Thank you.
Thank you so
Good night,
much.
everyone. Stay safe.
Good night. Thank you.
Thank you. Thanks, everybody. See you soon.